Okay, I think we'll go ahead and get started. So welcome everyone once again. Hopefully you showed up here at the right track. This is for the solution demonstrations, and we are happy to have all of you here. My name is Drew Hensel. I serve as the program manager for the Big Sky Care Connect project. And just a reminder as we go through this, if you have any questions, just please go ahead and use the chat box. Okay, so let's go ahead and get started. So here are the topics that we're slated to cover today prior to the demonstrations. We're just going to do a quick Bscc project update. So right now we're going to go ahead and cover some of the outreach, onboarding, solution implementation, and procurement activities. And we hope that you can leave our presentation today with better knowledge about Bscc and how a statewide HIE can bring value to your organization and the patients that you serve. And ultimately, we believe that hearing this information will generate some excitement for you to want to partner with Big Sky Care Connect. Okay, so first topic around outreach. So as you can imagine, one of the main objectives to creating a successful HIE is participation by organizations across the state of Montana. So due to that fact, we have a team of dedicated outreach coordinators that have been engaging with a multitude of organizations. To help facilitate engagement, one of the new strategies that we have adopted is to take a community-focused approach to build the HIE around communities that share in the care of patient populations. So the first community where this approach is being implemented is in the Billings area, and a well-hosted event was attended. It was a community roundtable that was a well-hosted and well-attended event that we had on October 29th, and that featured a panel of local healthcare leaders. And also, as you can see here from the numbers on the screen, we have made tremendous progress in signing up 26 participants to date, and we are close to signing another 20. And of those 26 participants, those are all listed here on the screen. This is up to date as of, I think, a day or two ago. And we have also, we're in the process of outreach to 102 facilities across the state. And also that includes 8 critical access hospitals. All right, so we'll go after the outreach portion, we go a little bit into onboarding. So once a participant signs a participation agreement and a business associate agreement, what they do then is enter into the technical onboarding phase. So the participants you see listed here on the screen are in that phase right now. And most of that includes working with each of the organizations to have them contribute data to the HIE. And that data can take, I definitely won't go into too many data details, but that data can take the form of HL7 messages, CCDs, anything clinical data-wise. And we also, as you can see on the screen here, are working with the Montana Medicaid Association. So we're also getting claims data from Medicaid that we are ingesting into the platform. All right, and then next up, just a little bit around solution implementation. Okay, so right now, these are kind of the core activities that we have going on within the implementation. So Intersystems, who you'll see a demo from here in a few minutes, they are the technology platform that we have chosen for the infrastructure of the HIE. One of the things that we've also layered in, and really the rest of these are all kind of different platforms that we're integrating with our core technology platform to offer additional services to enhance the offering of the HIE. So one of those things that's directly there under the core platform is the implementation of a direct secure messaging solution from Secure Exchange Solutions. We're also working through integration with the eHealth Exchange. So right now we're doing final production certification and testing. As some of you know, that will also enable us at a later date to connect to things like the VA and the SSA. So Dr. First is another one on here, which again, you'll hear a little bit more about here in a few minutes. But we continue to work with them on integrating their medications data into the platform. So that's continuing as well. And we hope to have that live here and ready for use when the platform go live comes up here also, and hopefully the next 30 to 60 days is what we're aiming for. Also, we have Collective Medical. So Collective Medical offers an ED alerting service, which you'll also see a demo about here in a little while. We also, as I mentioned on the previous slide, have Medicaid claims data that we're in the middle of doing validation testing of and ingesting into the platform. Another partner of ours is Carecom. So Carecom provides terminology services. So what that's doing for our platform is making sure that any coded data that we receive is normalized to certain code systems and that the descriptions of that data are consistent as they're being displayed or shared. And we're also working through some more technical details around how we ingest and how you're able to access 42 CFR Part 2 and sensitive data. So we've been working with committees and the legal team at Bscc to make sure that we're following all the requirements that are needed for the state, and working on implementing that here soon. Okay, just a little bit around procurement. So I touched on a few of the things that we're already in the process of, but a few more items that we have that are coming up on the procurement schedule as we move into the next calendar year. So those would be related to analytics and quality measurement. So right now we have RFP responses that are being reviewed with a subgroup that we've set up to review these things. And following those reviews, they're going through a scoring process. We'll be making recommendations on how we want to proceed from there. And then on the image exchange, so image exchange, we went out for an RFI not too long ago to make sure that we had really all the information we needed to be able to craft an RFP that would allow us to gain all of the information that we really needed to get from each of the vendors that are in that space, since it's a pretty limited space when it comes to image exchange in the HIE world. So that's getting close to going out for RFP and continuing the same process that I just spoke about for the analytics and the quality measurements. All right, that was a very brief project overview. So thank you for following along there. So if you have any questions, the information is here on the screen. You can call, email, or visit us on the web. All right, so I will go ahead and stop sharing, and then from there, I'd like to introduce Chip Gore from Intersystems, and he will be going through a demonstration of the technology platform.
All right, thank you very much, Drew. Yeah, as Drew indicated, my name is Chip Gore. I'm from Intersystems, and I actually am going to be sharing just a little quick display about who Intersystems is, and then actually show the technology real quick. Intersystems, for those of you who have not heard of us, we are a global company. We sell information infrastructure technology to governments and hospitals and hospital information systems, including health information exchange components. And we're highly ranked that way, and we're very happy that Big Sky elected to build their health information exchange on top of our technology itself. We partner both with the payer space, the life science space, as well as governments directly at a national, state, and local level as well. So like I said, we've been in the business for a lot of years doing this sort of stuff. We have information exchanges around the country, including our new star up here in the corner under Montana. We're very happy and pleased about that. The technology itself is what we refer to as health share. So it's an interesting problem of showing plumbing in an environment that isn't very interesting to look at plumbing. So what we've got set up here, and I'm going to show in the demonstration, this is actually a virtual machine running a full-blown instance of health share locally on my environment with just fake patient data. So we're not looking at real patient data in here with made-up patients on it. We're going to be looking at the what we refer to as the clinical viewer interface to this environment, which is what a clinician would see if they logged in directly to the HealthShare platform. But this viewer can also be embedded into the natural workflows of EMR environments and can be linked into securely from the secure direct messaging, where links can through signing in process can actually take you directly to patient records inside the environment. What I'm going to be doing here is just logging in my browser as a clinician by the name of Dr. Sam Farrell. He's one of our fake clinicians that we use for demonstrations. And the first place I get brought into is what we refer to as the clinical navigation environment. And then it will default into bringing our patient search environment on this. You'll note on the left over here, we actually have some components that are for navigation. Over time, Bscc will have the opportunity to integrate other applications into here besides just the clinical viewer environment and be able to link off of this. So once you've signed in, leveraging single sign-on can leverage different connected applications inside the environment. We can attest directly to relationships to patients, manage our cohort lists and such directly from here. But what I'm going to do for demonstration purposes, I'm just simply going to perform a quick patient search with minimal demographics that will then go reach out to the master patient identity management solution, come back with a list of likely matches, and we'll walk in and look at actual patient record from there and sort of show what a clinician or care worker or caseworker might see leveraging this user interface. So I'm actually going to be looking at a patient that we've completely made up named Raymond Chan. And we'll actually search for him. We'll find that Raymond Chan comes back as a patient list of 1. If he comes back here, here we go. Now this is a link to the patient's record, but this really is a link to a patient record from multiple different sources behind the scenes. What we have done on the fly when a patient is being retrieved from the environment through our indexing technology, we know which connected systems have told us they have content referring to this particular patient. So in each one of these different contexts, we see a different unique patient identifier from that content provider's point of view. I could just as easily gone in and said, hi, I'm this service provider or data source provider, and here's the patient ID I care about. And then through the patient master patient indexing technology would be linked back to this record that is then connected to everybody else. In this case, we can also see we have an iconographic view of what type of information is available from each of the different providers. So if I were to select and say, just show me information from, say, community healthcare, I would get all of this available information from them. What I'm actually going to do is select from the master view of the patient. So this is going to go and fetch from everybody. And when I select on him, he actually goes and retrieves dynamically, reaching out, getting the most current information from all of those providers, normalizing them, does appropriate source-specific translations into the right nomenclature, folds them together into an aggregated, what we refer to as unified care record. Then the unified care record is then presented as a complete composite record that is all of the information currently known that I'm authorized to see based on who I am logged in as a user, as well as consent that's been applied by that particular patient and the facilities presenting the information to saying what's available, what's not available, whether or not you have to break glass to get into them, and so on and so forth. And I end up with this composite view. By default, the landing view that I come up to is a summary page that is configurable. It will be configured to match Bsc's default layout, so it'll have the appropriate decided 6 panels on the top here. In this case, out of the box, we've got diagnosis, lab results, allergies, and meds, documents, and such in each one of these. This is what's referred to as a responsive designed interface. So depending upon what you are rendering this in from a tablet or a phone or a desktop environment, it will resize and shape based on that. So if a clinician is accessing this, say from a tablet bedside, they will get the tablet shaped view of things. If they are from a desktop, which is what I'm showing here, they'll get the desktop size view of that. Down the left side over here, we'll actually see, these are what we refer to as the chart books. These are clinical domains of interest. It's a way of categorizing a holistic view of the patient, such that we have the summary view, we have conditions that that are actually broken down to current and historical documents, so on. So you can read down the list here. In this display, anything that has a blue bar next to it, that means I actually have data in this record for this particular domain. So if you note, I have no particular immunizations associated with Raymond Chan, but I do have vital signs and procedures and histories and encounters. We look at the encounters, we can see they are across all the different facilities, presented in chronological order or reverse chronological order. And I can search directly on this to find a particular encounter that's of interest on this. Go back to the summary page here. We can see also that when things are presented, if they are flagged as information that is abnormal or out of range, we actually highlight that, as we have here with the CBC results that have come in this environment. If we actually go, let's say, look at our lab results in general, I can see both specific lab results that are most recent, pull up the, see what the references are, when the order, where it came from, when it was collected. I can also look at results from date ranges or group, so I can actually trend out the information, for example, and say, oh, this is my cumulative results here. I can also then turn around and have this graphed out. So depending upon the visual that the clinician or the caretaker or the individual who's using the clinical viewer is comfortable with, there's lots of different ways to render the information in a clinical meaningful modality. We have a breadcrumb way of walking our way back up to the patient level in general, including all the way back up to search. Within the patient view itself, the aggregated process of creating this composite view on the fly can also reach out and analyze the information as it's coming in and generate actionable alerts that are inside this environment. So for example, if a lab comes in that someone is subscribed to being notified for, there is a modality where we can see the alert that's presented in to the patient in here, but these alerts can also be delivered directly to their direct secure messaging or into the messaging framework of the EMR that's connected up to the environment. This is an extremely fast view. There is hours of depth that can go into the machinery on this, but I just thought we'd want to give you a quick overview on what to expect from looking at a composite view that's really only available in a health integrated environment like you would find with an HIE. As more and more providers become connected, the richness of each unified care record patient record becomes richer and more important. And when we talk about, as we were saying earlier, Drew was mentioning the CFR Part 2 data, there will be appropriate flash screening up here to make sure we've derived consent to see the sensitive data in the environment. And this will be configured and branded to match what Blue Sky, or Big Sky rather, expects this to look like. What I'm showing here is just the vanilla Intersystems unbranded view of things. With that, if anyone has any questions, please feel free to put them in the chat. I'm certainly available to answer questions in the Q&A on the end of this. And with that, I'm going to go ahead and hand this back.
Great. Thanks, Chip. Appreciate your time. All right. Next up, we're going to have Scott Fowler, Kurt Hess, and James Amfroy from Dr. First.
Hey guys, Scott Fowler here. Can everybody hear me okay? Great. We actually did lose Kurt in the process while we were waiting. He actually got pulled away into a personal emergency, so apologies for that. Kind of bait and switch on you here. So my little fast PowerPoint skills took your name right out of this real quick. Can you guys see my screen?
Sure can.
We're good.
Excellent. Great. Well, again, thank you for the introduction, Drew, and Chip as well. And you know, it's rather timely that we're kind of following suit to the Intersystems platform and Chip's presentation, because really Dr. First as a solution is a data solution. So we don't have an application to show you here today, but we want to talk about the data we provide and what we bring to the table, and what we're excited about. What, you know, the projects we're doing with Big Sky. So without further ado, just a quick overview here, and of course my navigation wants to be funny on me now. Here we go. So there's the faces of the team. That's myself and James. I'm Director of HIE Strategy and Solutions, and James is one of our executives in our enterprise sales team. James we're actually both Arizona natives, so we're the focus of the country right now for a variety of reasons. But we're here to really show you our suite of software. Now, James, if you want to do kind of a quick introduction of yourself, let me do myself, then you can talk about it and you can take the next few slides. My background for the last several years has been HIE. So I joined Dr. First about a year and a half ago, having come from a rival vendor to Intersystems at the time. But ironically enough, Dr. First is an Intersystems shop as well. So even more beholden to Chip and his team for their product. But I've worked in the HIE space and interoperability for the better part of the last decade. So that's a little bit about me. James, go ahead, take her away.
Yeah, and thank you very much, Scott. My name is James Amfroy. I am, as he mentioned, one of the enterprise sales executives here covering the western region of the US. I've been with Dr. First for about 5 years, and I work with a lot of health systems and HIEs, specifically around medication history reconciliation and bridging a lot of the communication gaps that we see today across the different care environments. So next slide. I want to briefly just cover some of the things that we're going to talk about. And again, if there's any questions, please feel free to put them in chat. We're happy to support those. But we're just going to give a high-level overview of who Dr. First is, what the partnership with Big Sky Care Connect looks like today, where we're taking this in the future. A lot of the medication history information that's going to be provided to the end users through Big Sky's platform. We're going to talk about that and what's available to you, as well as where Dr. First is getting that data from on the back end to provide to anybody who's trying to access through the HIE. And then we'll just give a brief overview about the other spaces that we're in within the healthcare industry.
Great.
Next slide. So just the 10,000-foot view. Dr. First was founded in the year 2000. We were actually an e-prescribing company, and that's where our core competencies lie. Today, we send about 110 million scripts annually. We pioneered EPCS. We worked with several governing bodies to create laws and regulations around that. Today, the bulk of any controlled medications that get sent electronically to pharmacies come through the Dr. First network. But since then, our footprint has expanded. We're now working with medication history, which is mainly the focus today, but as well as care collaboration and bridging those gaps and connecting care teams with payers to patients and their families and caregivers pretty much across the nation. Next.
Yep. All right, I'm going to pick this back up from James here, assuming you guys can hear me okay. So what we're doing with our Dr. First and Big Sky Care Connect integration is really providing the medication history that James was touching on to the Big Sky and its Big Sky Care Connect HIE and its community. The real benefit here is obviously you're going to get real-time relevant patient medication history and what we call clean, complete, and consumable data elements, and in doing so, you're able to leverage, your partnership with Big Sky to get you that very, very critical at the point of care, medication history information. Now, our current model, and I don't want to belabor this too much for the non-technical folks on the call, so I'll try to not be too techy here as I am wont to do. As I mentioned previously, we're also an Intersystems shop. So the nice part is that it's very like to like from a data perspective and an integration perspective. Big Sky's selection of Intersystems allowed us to sort of trim a lot of the fat off of varying or disparate interface systems and engines. And in doing so, we're able to leverage existing standards to really connect to the Dr. First medication history information. So Big Sky is actually connecting to us through IHE services, and if you're familiar with the interop space, you probably know what those are. And we're providing CCDs back, and they're able to display that information for their end users and their participants in the HIE platform in what Chip was just showing you guys with the Intersystems, the Intersystems environment. As he mentioned, that's going to be co-branded and all, kind of white glove branding treatment with the Big Sky information and branding. But really the wealth of information you're going to be getting from us is significant. And we'll show you a little bit of why we believe that ours is the kind of the best in the space. But that's our current state and our current project. But I wanted to also show you and the team here what kind of the future state could be, and what we're also doing in other HIE spaces and in the market. In other offerings, we're able to leverage our existing network of Doctor First facilities. So we'll have, we have over 20 partners already in the state of Montana. Several in the Billings area. I don't want to name drop too much, but with those partners already using our integrated solution, we're able to actually leverage that agreement and share data with the HIE on their behalf. So if we had a mutual client or a mutual participant in Montana, we're able to share the data with Bscc directly, transactionally. And the nice part of that lift is that there's no requirements from a development perspective for the partner hospitals. We're leveraging our existing connections and doing that. So in other markets, we just substituted a symbol for HIE here in the center for where we find Bscc today. We're pursuing this model, and it's really starting to benefit both sides, because as Doctor First expands their footprint in any particular state or region or HIE market, using this model, we're able to also enrich our information, because we're able to get, as part of that sort of transactional relationship from a data perspective, we're able to get the discharge summary meds from those partner hospitals. And that's going to inform our medication sources and give us additional details on meds, so that in those markets, not only are we growing our footprint, but our data footprint and our understanding of the patient population in those markets grows with us. And that's really the kind of mutual benefit model that several other HIEs are pursuing with us. And we have actually several instances of this live in production today. Up next, I do want to discuss really generally our data sources. So I mentioned the complete, clean, and consumable data model, and how we really hang our hat on our data. We have a variety of sources. So if you look down the left-hand side, you'll see that we've got pharmacy and PBM data sources. And that's leveraged through our partnership with SureScripts. So we are a SureScripts partner, but we have additional data above and beyond the SureScripts content that's provided through that partnership. We actually have additional sources where we've got local health plans and PBMs. We've got our individual provider network that James touched on briefly as we went through the our Who Doctor First Is slide. We've got over 260 connected EHR partners, and you see at the bottom several of the bigger brands from the inpatient space with Epic, Cerner, Allscripts, and Meditech. But we also have several ambulatory integrations. We've got integrations across the board. We've also got our standalone MedHistory product and e-prescribing products that allow us to get data that nobody else really has access to. And as I was mentioning on the previous slide, we're also now leveraging our really strong partnerships in the HIE community to get access to additional sources for that data. So we're able to get data from, as you see here, not only prescription sources, but we're getting it from pharmacies, we're getting it from payers. So we're getting a richness of data that SureScripts and their model helps provide us, but we really extend beyond that with our market. From there, the clean piece is one of the most important components. So we're able to prioritize and basically dedupe all of the information presented in the record that we have access to. So we're grouping multiple fills together. We're trying to roll these things up and provide data access that way. And then on top of that, we've got what we call our SmartSig tool. And SmartSig is our kind of industry defining, and I speak kind of self-aggrandizingly there, but it's a really a big differentiator for us in the medication history market. And SmartSig allows us to sort of normalize disparate data sources. And what I mean by that is, oftentimes, especially in the HIE business, or anybody who's in the interop suite of software and working in those types of interfaces, know that we have standards in the industry, maybe HL7, IHE, CCD, etc. But standards is a very loosely followed or loosely framed term. And while one vendor may say that these optional parts of a standard of a CCD spec and HL7 spec are optional for them, another one may require the utilization of those fields. So you see a lot of disparate data sources. We've also got different vendors for drug dictionaries and libraries like First Data Bank and Multum. And SmartSig allows us to really bridge the gap across all of those platforms. We've actually got a patented AI tool that's going to normalize all of that SIG data that's free text or partial and incomplete SIG information, and normalize that to all sorts of discrete data elements. So you get the dose, the frequency, all the individual components that make up the SIG as those discrete data elements. So that's something we're really, again, very proud of, and a real key differentiator for us in the space. James, is there anything you wanted to add on this slide?
No, I think you covered it all.
Great, and I appreciate that. And I do also want to say that we've also got our integrated platform. So many of you in the call, I'm not sure of the audience quite yet, but we do have, like I said, over 20 hospitals in the state of Montana that are already partners with Dr. First. Several of those practices are using the integrated solution or are about to be onboarded to the integrated solution. This, the service from Bscc gets you the really great access to the data, and this model allows you to kind of take it further. But with Bscc in the picture, the value they're really providing the community is really second to none from a medication history perspective. James, just to kind of quickly show you guys, unfortunately, like I said, we don't have a screenshot or an app we can use because we're just sending information. So if we were to show the implemented version, you'd see, much like Chip was just showing you with Intersystems, you'd see the medication being able to be consumed by the Intersystems platform and show up as discrete data elements within the medication sections there. This is just a sample of some of the basic information we've got. This is a screenshot from our legacy standalone med history product. But you'll see here that we've got different meds, and we've got the little pluses on the side where you can see the roll up for multiple fills. You can see at a very small glance, the middle column, I know that's pretty small text, and I'm even struggling here a little bit, is the directions. We've got the quantity, the day's supply, the number of refills, the prescriber, the pharmacy. So we're able to gather all of that information, again, from a variety of data sources. So we're getting fill and written and adjudicated claims data. So we're really kind of casting a wide net on our data sources to bring as full of a picture as we can to that patient's medication history. Just some additional screenshots from some legacy systems. Our poor patient, Daryl Anderson, has been through the ringer. He's a test patient that everybody uses. So he's on a lot of maintenance meds and a lot of painkillers. It's a really unfortunate scenario for Daryl. But just to jump right in and kind of wrap things up, I do want to show just a couple little additional slides. And James, maybe I can pass this back to you as we kind of round this out.
Yeah, absolutely. I appreciate that. So as Scott had mentioned, medication history is really the big benefit that we're bringing, hopefully to the community to leverage when documenting meds on your patients, when they're coming into the clinics, when they're coming into the hospitals, and just providing that insight they're taking from a national perspective. Beyond that, Dr. First's concern really is with the whole medication management life cycle for that patient. So another piece that we like to focus on really is looking at medication adherence. We all know that, the patients spend very little time in the hospital or very little time in the clinics, but the majority of their time is spent outside, right? And so how do we manage patient behavior and start to augment that in order to get them to take more care in their own care, so to speak, right? So one of the ways we do that is through this application here. We call it RX notifications, but essentially once a medication has been prescribed to a patient, we'll reach out to that patient, let them know that they have a script that was sent to the pharmacy for them with information on what the medication is, what the side effects are. If there's content like videos, we'll send those as well. Because we all know there's multiple reasons why patients don't pick up meds. One, they're unfamiliar with it. Two, it costs too much. Three, it's just the avoidance factor. But I think we're really trying to address that here. The other piece that we look at too is the cost, right? So what is the out-of-pocket cost for that patient, and taking into account what their current deductible is and where they're at as far as meeting that, and then applying discount cards, coupons, rebates in order to drive that cost lower that the patient can access right within this application, and then a pickup reminder so that they can schedule a reminder in their phone. You know, we're all busy. You get a prescription that's sent, you have to go back to the office. It's always good to set a reminder so that you know when to go back and get your medication. The good thing I want to mention about this too is this doesn't actually require the patient to actually download an app. This is something that, you know, gets sent to them through an SMS text. They're taken to a secure screen. They just validate their identity, and all this information is available to them. Scott?
Yeah, thank you, James. That really sums up that effort. And again, not to make this too much of a kind of a sidebar here. I don't want to get too far off the core goal with Bscc and their excellent integration opportunity here. But the real key for me in this model is the 70 million patient encounters. Anybody that knows the patient space in healthcare is always sort of the weirdest and hardest wall to break. And it's really a testament. I'll be honest with you guys, and I probably shouldn't say this, but when I first started with Dr. First, I was blown away by the technology of this particular feature, but was always kind of wondering what their engagement rates were, because engagement rates in my experience with the patients directly were so low. But when they came up with the numbers that they're actually seeing in this, and we actually have exceeded those since then, we're upwards of 80% of the patients messaged are reached. 65% of those patients actually engage with the message, and of that 65%, 99% of them are retained, and we get very, very minimal opt-out rate. It's a very, very big deal and a very, very, very key component to that med adherence piece that James was discussing. And here's just some additional kind of RX abandonment rate stats from the country that we're seeing, and how we're able to improve those, you know, before and after the texting solutions out there. So if you have additional questions about Dr. First, you can visit us on the web. It's pretty straightforward, www.drfirst.com. And here's some additional information, just kind of name brands of our additional solutions. But James, anything else you'd like to add today before we wrap this up and give this back to Drew?
No, I just want to thank everybody for their time, and I want to thank the Bscc team for allowing us to present here. So thank you very much. We were excited to do so, and appreciate the opportunity.
Yeah, and I want to echo those sentiments, you know, to Drew and company, and even Chip for allowing us to kind of ride your coattails here a little bit with the Intersystems platform. Thanks everybody for your time today, and I will stop sharing and give this back to you.
All right, Scott and James, thank you. Great presentation. All right, so next up we have Rachel Lieber from Collective Medical to talk a little bit about their ED alerts.
Thanks, Drew. Thanks, everybody. Drew, can you give me a holler when you can see my screen?
We can see not the right one. How about that?
That's very fair. I'd like to show the right one. There we go.
All right, you're good. Thank you.
Thank you. So good afternoon, everybody. It is, yes, definitely deep into the afternoon. And I know you've been listening to a lot of information. I want to try and make this as quick as possible, because I get to focus on the ED physician workflow and the ED nurse workflow. So first of all, Collective Medical has partnered up with Bscc Care Connect, much like Dr. First and Intersystems, to really provide you with an integrated suite of solutions that should really bring the care coordination community in Montana together. Collective Medical has been doing this for a really long time. I've been a part of the company for about 5 years now, came over from your Missoula folks, Providence actually, and really focused our attention on what does an ED physician need at the point of care in order to really understand not just what the patient is presenting with as their chief complaint, but also what might be pertinent to that patient's care history as we're doing that initial intake assessment and care plan in the ED setting. So we've been very excited to work with Bscc Care Connect to deploy our platform and our alerts, which we're referring to around Bscc as the ED alerts, leveraging a lot of the interface work that will be put in place with Intersystems and Bscc Care Connect HIE. So how does this work? So all of your hospitals are connecting to the HIE. Collective Medical is connecting to that HIE as well. We're going to be able to pull that PHI across for any patients that arrive at your emergency rooms, your hospitals, and then we're going to deliver back to your ED physicians and your ED nurses within just a couple of seconds a really concise alert, letting the ED provider know, hey, there might be some other things about this patient you want to keep in mind as you're doing that assessment chief complaint care plan. So who is Collective Medical? So we are a cloud-based SaaS ADT company. We have a long history working in what I like to refer to as the upper left, or the Pacific Northwest, where I am based out here in Portland. We are based in Salt Lake City and really have focused on leveraging what we call ADT, or hospital event notification data, to connect to the disparate care coordination community. We have a lot of success working into the emergency room space, and we are connected to all of the hospitals and emergency rooms in Oregon, Washington, Alaska, and we're also actively deployed at Community Hospital in Missoula, as well as St. Pat's in Missoula, who have been using our platform for a very long time. And many of you might actually represent one of those organizations and could definitely chime in during discussions on your experience getting our alerts. So just to give you a little bit more of the walkthrough of how this works. So patient arrives in the emergency room setting. The intake nurse or staff, triage staff in the emergency room setting, enters a small amount of information into the electronic health record. Many of you use Epic, some of you use Cerner and Meditech, and that is really your place of work. That is where you start the encounter in the ED space. By entering a small amount of information into the system, an ADT message is sent out in a secure way, leveraging those HL7 interfaces that the IT team has put in place, and says, what else do we know about this individual that might be relevant? And within just a few seconds, returned back into the EMR that you use as your place for daily work, that concise report is populated. Why do we find these so helpful? First of all, the notifications and the ED alerts are sent for a good reason. So we don't send an alert. I heard a little bit of talking about noise or alert fatigue. We are very intentional about working with you to make sure that we send the alerts if there's a good reason. For example, if you have a patient that has just presented in Helena and they've actually been to 10 emergency rooms over the last year, that might be important to understand this patient's situation. Maybe lacking secure housing, maybe needing better connection with primary care or behavioral health, or they've moved into the community and have recently moved from elsewhere, and we don't have a lot of that relevant historical information to understand the full patient condition. They're filled with actionable information. So we're also very conscientious from a ED physician and ED nurse role. It's very important that the information is presented to them in a concise way, focused in on what is the action that I might need to take off of this information, and I can consume it and digest it in, it says 60 to 90 seconds. It actually could be shorter than that. I like to call it a snapshot. We organize this information based on that network connection we have with Big Sky Care Connect HIE, but also with all of our national partners. One thing to also keep in mind about Collective Medical is that we are a national hospital event notification and ADT organization. So for example, if one of your patients recently visited Seattle Children's in the Seattle area and then came back to Montana, that data from Seattle Children's would also be presented in the ED alert notification. So you get a really nice global, we're not a global company, but a global sense of where this patient has been across the entire Collective network, which is a national network of hospitals, emergency rooms, and skilled nursing facilities. And I know I'm moving quickly here, but I'm conscientious of making sure that we get your questions in here. So some of the reasons why, when we talked a little bit about making sure that we send you a notification for a good reason. Well, what's a good reason? So the reasons that we generally start from, and then we customize with you from here, are these 6 categories. First, we'll talk a lot about high utilizers, individuals within your ED who tend to use the emergency room 5 or more times. That's a really good just starting line in the sand to kind of say, hey, there's something else we need to be aware of with this individual, whether they just moved here, they have a community, or they just lack connection to primary care and continue to feel more comfortable in your emergency room. And we know we have some patients that fit into that demographic. We also talk about traveling patients or rising risk. These are individuals that have moved between 3 different emergency rooms. Think about that. They've gone to 3 different emergency rooms, maybe Kalispell, Billings, and Missoula, and your EMRs are only connected well through that ED alert and through Big Sky Care Connect. And understanding that patient's travel behavior outside of your health system is really vital to your ED physicians and your ED nurses. Patients with care guidelines, so individuals who have created a relationship within case management or care management. We heard a lot about some of the primary care organizations around Montana that are starting to create a case management relationship with a particular member. This is a way that we can advocate and make sure that those care goals that the care manager are establishing with their patient are reflected to the ED physician as just something to keep in mind as the ED physician is doing that initial intake and assessment. We also alert on any patients with a history of security issues within an emergency room or inpatient setting or safety. And I'll talk a lot about this because it's really important to collective medical. It really is one of our core values that in our platform, we think about the safety and security of our healthcare workers, our first responders, our individuals who, if you do not feel safe at work, it makes it more difficult for you to provide care to vulnerable populations. So when I show you the actual alert, you're actually going to see that security events is actually right there at the top of the notification. As a first responder myself, we always like to say, is this scene safe? Once we establish safety, then I can enter and start to provide care. And so we follow that within the platform. And then we also look at conditions for which are documented in the EHR and might not be immediately relevant or made aware of as the patient is arriving in an emergency room, for things like history of sepsis or history of COVID-19. And I'll show how those appear too. I know this is a little bit blurry and it's not everybody's EMR. It's very busy, but we call this the Trackboard. You're going to hear me talk about the Trackboard. What I want you to walk away from in this presentation is what we are delivering is the notification into your emergency room. So you are going to see this alert either in your Trackboard or in your EMR, or it's going to come off on a fax printer if that's more useful for your current workflows. And what you see here on the screen is where the EDI notification starts to appear in the Trackboard, regardless of whether you use Epic or Cerner or Meditech or Sorian or T-Systems. We have worked with all of those vendors, but we know how to populate that notification right where the ED physician is starting to look and understand who is the next patient that I am about to go introduce myself to. All right, so with that, I'm going to flip the screen here and actually give you a demo of how this looks. Okay, so what you should see on the screen now is actually our demo environment of your EMR. It doesn't exactly look like Epic. It doesn't exactly look like Cerner. That's because we can't actually show those EMRs. They're not our systems. But this gives you a general sense. When your ED staff check a patient in or they go through intake and triage, a small amount of information is entered into the EMR. Important demographic information: first name, last name, chief complaint, date of birth, social security number if it is collected, address, phone number. As soon as that information is collected into the EMR, like I said, and the encounter is created in the EMR, patient Jack Nolan is here today for chest pain. Soon as that is created, a notification is sent to Collective Medical and Big Sky Care Connect saying, what else do we know about this individual that the ED physician may or may not be aware of? And within just a couple seconds, an alert comes back and a notification that's succinct, concise, action-oriented, quick summary snapshot of the patient's relevant history from outside of my walls and sometimes inside my walls is rendered back inside of the emergency room's EMR or will immediately print on the printer. Like I said, security events right at the top of the notification, indicating that this patient does have a history from another facility outside of my walls where the patient had a little bit of a situation around assault with staff. That is very helpful to your ED staff to be aware of as patients are entering into their work setting and in the emergency room, other additional controls that might need to be put in place as we start to help the patient with their chest pain. Next, you see those care guidelines. These are care recommendations, suggestions that the outpatient side has said, hey, you might want to keep these things in mind as you're interacting with my patient who I'm having a longitudinal relationship with. We're working on a few things and things are to keep in mind. One that I love here is that care coordination note. Call the daughter at this phone number if this patient arrives in an emergency room. We so often hear that just some of those just little things, little pieces of information that might not be immediately obvious to the ED physician are now put right in their workflow and eases their way as they start to take care of a vulnerable individual. Moving on down, I can also see some more rendered care history, other things that might want to be thought about as we're assessing the patient for chest pain, as well as a 6-month look back of every emergency room, inpatient stay, or skilled nursing facility that this patient has had care within in the last 6 months. What you can also see here is that, again, we are a national network. So if there are encounters, which I'm sure there have been in many cases outside of the state of Montana, they will also show up in this care history. And I think about the proximity of Montana to our partners at Intermountain down in Utah, or our partners with Providence and Deaconess in Spokane, or St. Luke's and St. Al's in Idaho. It is so important that you are also aware of the patient's care that has been done in those adjacency and local areas that we know patients move. And so we find this to be very important to ED physicians. Finally, I like this quantitative summary. It's very interesting for ED providers to understand if a patient has an ED medical home because they contact that other ED physician at that other facility and say, hey, what are the things you're working on? It sounds like you've seen this individual a few times. And to wrap it up, we also work with state-by-state PDMP directors to be able to actually render PDMP, prescription drug database information of a patient's prescription history inside of ED alerts. I will caveat that this piece of the alert is not going to be rendered at this time in Montana, but it is something that Collective Medical, our partners at Big Sky and MHA are working on. And it's always a piece of the notification that can be added once we get that policy work done. And finally, care team information. These are the phone numbers of primary care physicians, behavioral health physicians, and other individuals who may have, again, that longitudinal relationship with the individual that can be really helpful to understand their conditions and needs. Okay, so that is the EDI alert. And how it will be shown up as you add on the ED alert through the Big Sky Care Connect services and offerings. Wanted to keep this very clinically focused. I also can spend time during the Q&As really talking about the implementation process, but much of it really relies upon what Drew and Shweta and the great team at Big Sky have already outlined in terms of how you would onboard to Big Sky with an interface. And then our team will work with you to make sure that we render that notification back in your EMR, in the Trackboard, or on a fax printer in your ED. Drew, I think I'm going to hand it back to you and stop sharing so we can get some good questions going.
Yeah, thanks, Rachel. Appreciate your demonstration here today. And thank you to everybody, Scott, James, Chip, really appreciate your time today and walking through all the different services that we're offering here as part of Big Sky. So thank you to all of you. All right, so without further ado, I think we will go to questions. All right. So I know there were a couple of questions that Chip answered in the chat. Chip, did you want to expand upon either of those?
Sure, I certainly can. Yeah, one of the questions that was asked was participation in Medicaid or any other payer type program. That is what we would refer to as a clinical domain. My demonstration patient didn't have that and wasn't configured, but that would be configured as one of the tabs on the left hand side where you can, from the patient's view up, say, oh, they are a participant in this particular group or cohort, that then you can drill into. It shows up just like the encounter history and the other history components. You will see them in and out of different programs if they come in and out. Oh, there's my video. My video was off. Sorry about that. I was gesturing away and no one was seeing me. Let's see,
it's only effective if you can use your hands, Chip. That's the way I
lived in Italy at one point. I learned how to talk that way. That was one of the questions. What was the other question that was on there?
It was around there were two. There was one around the provider list and the other one was around.
Yeah, David had asked about the recently viewed or going back to patients that you've seen. Part of up at the navigation tier level, there's a dynamically created list of most recently viewed. So single click, you can go back into a patient that you've already viewed. There's also the ability to have a dynamically created cohort of patients that are appropriate for you, where the systems can say, these are the patients I care about, where they can, without having to go through the search process, single click directly into the patient's longitudinal record. There's also the machinery in place where you can, a clinician or a caregiver can have a list of preferred patients where they simply add on, this is a patient I want to care about, I see frequently, or plan on seeing and calling. So you can prep a list that's individual to you. There can be dynamic cohorts that are generated by the machinery under the covers, as well as just the most recently viewed component. Hopefully that covers the question that David had asked. Are there any other questions? Scrolling through the list, he says. You're back on mute there, Drew.
I'm definitely on mute. I'm pretty good at that. Luckily, it popped up and told me I was on mute, so I didn't say anything profound. I don't know that I ever do, but David and Matt, does that answer your questions? If not, please just go ahead and put something back in the chat and we can address those further. There was one other question around, would the slides be available? We are making the recordings of this session available, so you will, they will be available on the website, so you can watch these again at a later date. I'm staring at the questions, the chat screen. If anybody else has any questions, we're eager to answer. Too effective, everyone, too effective.
We've either put them to sleep, answered all their questions en route, or they're thinking of clever things.
I take full blame for the asleep part.
Well, I would certainly, for one, like to add my appreciation for those of you who've joined and shown an interest in this machinery underneath here. We're very excited about the relationship with Big Sky. I think this is going to be a wonderful long-term engagement for everyone who's involved.
Yeah, thank you, Chip. Okay. Well, if there are no further questions, we, as Chip mentioned, I'll also just thank everyone for your attendance today. It's been hopefully a great informational session. You've learned a lot about the Big Sky Care Connect platform and also some of the other services that we're offering as part of the HIE. And once again, thank you. If there are any questions, I can put the contact information back up and feel free to reach out to us via any of those channels, and we will answer your questions accordingly. I'll go ahead and place that up now. And if I wouldn't have 52 windows burying it, of course I would do that. All right, there we go.
Thanks again,
Thanks
Drew.
again, everyone.
Appreciate it.